Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have a very special guest, Dr. Rahul Bhandari. Welcome to the podcast.
Hello, pleasure.
Yeah, so you are local in Clearwater in the obviously the Tampa Bay area, and I know we've had some discussions on the suffering of hurricanes, but we both survived and are okay. And I think, what you have to bring today is pretty exciting. So I'm excited to hear about, who you are and what you do. So why don't you tell us a little bit about that, and then we'll dive into our topic.
Yes, absolutely. I'm a practicing board certified radiation oncologist based in the Clearwater, Pinellas County and surrounding Tampa areas. Primary practice is based in cancer treatments, so that does take up 90% of our clinic-based practice. In terms of radiation oncology, in medical school, there's not any exposure. I would say not much, but really not any. Maybe there's one subchapter on radiation therapy under the cancer section of our medical school training, but otherwise there's no exposure. It's really, if you catch the bug, then you have to pursue it yourself. So
Mhm.
personally, I caught the bug fourth year of medical school. I knew I wanted to get into in the oncology world and practice oncology care, but wasn't sure what discipline, surgery, medical oncology, wasn't even really privy to radiation, but got exposed to it and I jumped right in. And in the radiation world, it's very, very much so academic based. So that's where I started getting into the academic side of things, research side of things. I went to George Washington University in DC Medical School. They did not have a radiation program there, but Georgetown, our neighbors, did. So I jumped right in there. They welcomed me with open arms. Spent time there, and then I went to Northwestern University Radiation Center after and spent a year there publishing and rotating through their clinics there. And then I went to residency and went from there. But it is everything for me. It wakes me up, gets me excited. I love what I do.
Cool. Yeah, definitely want to be doing things that you let light you up. I was excited to see that your like GW and Georgetown connections as, I did training in Baltimore and actually my brothers went to Georgetown undergrad. So it was neat for sure. DC is a fun area. So tell me about what is, low dose radiation therapy and why have I never heard of it?
Yeah, absolutely. The primary reason what I'm here to discuss is low dose radiation therapy. Like I said, primarily our practice is based on treating cancers, which we prescribe high dose radiation therapy. So don't want to get into too much details and bore folks, but in terms of just radiation, for example, head and neck cancer, prostate cancer, those types of malignancies are receiving around 7 to 8,000 plus units of radiation, and they are getting about 200 units of radiation daily. And for example, head and neck cancer, they will come for 35 total treatments. So over 7 weeks, they'll get 200 units a day to equal 7,000 units to that primary malignancy. In contrast, osteoarthritis, or really any inflammatory disease ending with itis, is what we can treat now effectively. So, for example, osteoarthritis, tendonitis, bursitis, synovitis, endocondylitis, tennis elbow, golf elbow, things like that. Anything with local inflammatory process, we prescribe low dose radiation therapy, which means, in contrast, we're giving about 4% of the total radiation dose to the joint space of interest. So a joint osteoarthritis patient will get half a unit of radiation per treatment, opposed to if you remember, the 200 units per treatment. So in entirety, a joint will receive 300 units over 6 total treatments. So half a unit, they'll get 300 units, which is what a cancer patient plus minus gets in one sitting to their cancer, and then 35 total times. So that's why it's considered very low dose therapy. It's about 4% of a cancer dose.
And that's throughout the whole course of the treatment.
That's correct.
Okay.
Yes. So that
4% total. Yeah.
and in radiation and just in terms of biologically and all that, we treat with a certain low dose per fraction. Obviously, it depends on the cancer histology, site, etc. All the fractionations dose per treatment are different. Total dose will be different, but we're treating at a small dose at a time, and really, it's giving the chance to the body to repair overnight. So
Mhm.
because we're, high dose is going to the cancer itself, some of the normal surrounding normal tissues do get exposed to some radiation dose. Now we know what each organ they have their own tolerances, so we make sure we don't surpass those limits. But we have to go slowly because 6 hours later, after radiation is given, those normal tissues repair. But if we gave that full dose in one sitting, it's a critical issue. Yeah, that would
Yeah.
cause a lot of damage and the normal tissues wouldn't repair. So that's what we're essentially doing. And
Okay.
and so low dose, they, through animal models and clinical research and all that, I'll get into how long, this has been around actually. It's pretty miraculous, surprising. But animal models, this half a unit of radiation was the exact dose that caused anti-inflammatory response. And so there is the multifaceted mechanism in terms of how it affects the local inflammation in the area. And that's what we're essentially treating, decreasing the inflammation.
Mhm.
But any higher dose over 1 unit would cause a pro-inflammatory response, which we do see when we treat cancers in local sites. We will cause inflammation as the dose builds up in the local area. But really, this ended up being the magic dose through multiple studies over decades of this magic unit caused anti-inflammatory, but it was that sensitive fine line where if you went a little over per fraction per dose per day, it would cause pro-inflammation. So that's how we landed on this dose of half a unit per treatment.
Yeah, that's very specific for sure. So, Dr. Bhandari, osteoarthritis, right, is becoming increasingly common, affecting millions and millions of people. Can you explain why osteoarthritis is such a difficult condition to treat with the current methods that we have?
Yes, as we know, and it's a perpetual growing problem every decade. If you look at the statistics, it is the second most debilitating chronic condition. It is the highest financially burdening chronic condition in the US. And then you look at what's associated with osteo, higher depression rates, cardiovascular rates, obesity rates, lack of mobility, everything where you need your joints to move and help with the rest of your healthcare and body, fine tuning it, you're kind of sacrificed. So it does provide a big burden on the healthcare system and then, in the economics as well. But if you look at osteoarthritis, it is the leading chronic condition when you get into it where we don't have effective therapies yet for this chronic condition that are longer lasting or are really getting down to the bottom of it. I do want to say before I go further, I am a big proponent, especially as a cancer doctor, of preventative measures, the holistic approach. Start at the root cause, tackling that to begin with in the global healthcare world, obesity rates and all that. But when we're having patients already diagnosed and they're sitting in the primary care physician's chair and they've been told, or orthopedics chair, rheumatologist chair, we have no options left for you at this point, which is a common news that is delivered to them at a certain stage of their osteo, which is true. We really, if you get down to it, there is a stepwise approach in the US. It's conservative measures. You come to the PCP's office, you complain of joint pain, they say, let's try conservative measures, weight loss, rehab, such. You come back a few months later, didn't work, let's try orthotics, things like that. Maybe even try pushing NSAIDs at that point, which we know long-term NSAID use, cardiovascular FSGI bleeds, that's a whole sequelae as well. If that doesn't work, they'll suggest injections, steroid injections, different hyaluronic acid injections as such. And then, as we know, osteoarthritis is a progressive, debilitating disease over years, unless, if we get down to the root, if you do see weight loss and all that, and or serious rehab, there is a way to turn around, but it's debilitating disease. There's a certain point, patient walks in the doctor's office and they are told, and that's really how I'm getting my patients, given this news of, I have nothing left for you. There is
Mhm.
no other options. Replacement is the only option. And then, half of them aren't good candidates because of their age and comorbidities as such. But that is really where we're at. And we're also learning simultaneously what the underlying mechanism is, where, first we know it's cartilage destruction, joint space narrowing, bone destruction, nearby sclerosis. We're now noticing that it is multifaceted. There's also changes in the synovium, in the ligaments, in the bones, obviously around in the whole joint capsule in entirety. We are realizing it's multifaceted. So one treatment here and there might not handle it. And then even steroids, which is the standard of care here, eventually, we know you can only get so many injections. A, B, we know that it can cause cartilage destruction down the road. So it's almost going against it. And so I would say to end it, right now our therapies outside replacement, which is, replacing the actual structure because becomes a structural problem too. Outside that, our therapies are masking therapies. It is just to mask the pain or the symptoms, and with that, hopefully increase function. But it's not getting down to trying to tackle or treat what is causing the pain, what is causing the dysfunction. And so we know half of it's structural, the joint space narrowing, loss of that. But the other half is the inflammatory response that is occurring and is building through the years because the joint space isn't getting better over time. It is becoming more destructive. The space is narrowing, and the immune system is just trying to handle it through the years. And in fact, it's almost working against it and causing accelerated destruction.
A couple things, a couple comments. One is I'm an obesity medicine specialist, and I totally agree. Getting at the root cause and working, on whatever nutritional foundation and things to do. But sometimes, we see that they may have weight so much in excess that they cannot move around to say, okay, you need to move more, right? So the kind of things are important. So as I see people losing weight with me, one of the best things they say is that they're able to, move more, feel better. So that's good. But sometimes, they may need something like this to help them be able to do that and even have success in losing weight. So that's definitely a great thing to
Yeah.
have an option for. And
Yes.
then you mentioned NSAIDs, just so everybody who's listening knows what that is, but non-steroidal anti-inflammatory. So things like ibuprofen, Advil, Motrin, naproxen, there's diclofenac, all sorts of ones. And yes, like we definitely turn toward those to help patients. And like you said, there's a cardiovascular risk, there's a kidney risk, there is a GI bleed risk, and some people just can't take them. And then obviously, sometimes people would maybe move toward another medicine, might be like an opiate, and that's definitely not something we want to go
Yes.
doing either, right? And then you mentioned the steroidal component as well, and definitely, that's standard of care, which is we don't want to do systemic steroids, but at least the local injections can help, and you only can do every 3 months or so. Having this alternative idea is fantastic, I think. And then, like you said, a lot of people are being told, like, you got to get it replaced. But like you mentioned, a lot of people think of or osteoarthritis as like a structural problem, like bone on bone. And I don't think we do here as much, even though we give the anti-inflammatories, that it is an inflammation problem. So it's almost surprising to hear that, I think, for the general public, of that some sort of radiation therapy, which is focusing on the inflammation, can actually improve this problem. And I know we can talk about the other problems that this helps in a minute, but I just think that's so interesting that they may not think that, right? So,
Mhm.
yeah.
Yeah, and even get they with animal models, they got down to the nitty gritty of what cells radiate low dose radiation is actually affecting and killing away. And specifically, there are four mechanisms. There's the anti-inflammatory mechanism. It reduces the production of pro-inflammatory cytokines like interleukin-1 and TNF, tumor necrosis factor. Those cells go away. So it reduces production and recruitment of pro-inflammatory cells, and then it modulates the actual immune cells that are already there, such as macrophages, lymphocytes, mast cells. So it also kills away those cells in the meantime. And then it also has shown properties of cartilage and bone production. So osteoblastic mineralization, and then prohibition of osteoclast cells. And then the last thing is it has endothelial proliferation to help with the healing process. So it is tackling, like you said, and what I tell my patients, I'm not doing anything affecting the actual structure here. But in your case, symptomatically and subjectively, because we don't know in terms of symptoms, I can see a radiograph and X-ray. I can't really tell. It might not line up with the actual presentation. Sometimes it looks bad and they're not with pain. Sometimes it doesn't look so bad and they have 10 out of 10 pain. It's hard to pinpoint per X-rays per se, but I said one thing will help with is the inflammatory process, the pain signals that are released there, the destruction, the destructive cells, delaying those or at least eliminating those, so you can get back to working. And to go off on what you said, that's one things I always in my consults and follow-ups with is if you go through this treatment, I am a big proponent of physical rehab because to sustain this, maintain this relief, if you have such, you have to build the structures again around it that have been dormant. And the body diverts its resources very well. It weakens the muscles that are being used as such. So let's get back to it. Let's get you moving again. Let's work on these other things. It is again a multifaceted approach there too.
So with all these generation and destruction of the certain cells, is it localized to what area is getting the radiation treatment? Okay.
Yes. Yeah. Great question. So radiation, the way it works, it's local therapy. And so the way I describe it is surgeons, they use blades and knives. We use lasers. But if surgeon goes in and cuts in a specific area, that's what they're addressing. And if you have side effects, it's just in that area that they're poking at. And same thing with us. We're giving external beam radiation, but very local with our technology, where if we're treating a little circle, we're only off by millimeters. That circle will get radiated and the dose fall off is so steep that the surrounding tissues don't get exposed to much radiation. So osteoarthritis, all that, just treating, for example, the knee, just a knee joint capsule with a margin of a few centimeters, but nothing else in the body gets affected by radiation. And while we're extra okay with going through with this, despite all the data, is because when we're treating joints, there's no critical organs nearby, near the knee, the elbow, all that jazz. All the critical organs are in the central part of the body, and we can displace the knee or whatnot away and just treat that locally, so nothing otherwise gets exposed. And what do we have here is just tissue, muscle, tendons, bones that are highly resilient to radiation doses and that heal pretty nicely. So yeah, very local therapy. And if you have side effects and radiation, it'll be in the area we're addressing.
Can you explain kind of how you keep it local, how that works?
Yes. So what we use in either cancer or osteo or benign conditions is called image guidance radiation therapy, meaning what we'll do with any patient coming in needing radiation, we'll do a planning CT scan. And it's usually in-house at the radiation center, but it's a low dose type of CT scan with donut-shaped machine, the whole ordeal still. But we CT scan the area of interest. And that CT is what we use to plan the radiation. So we really have drawing tools where we draw the organs and cancer or area of interest, and then physicists, dosimetrists, planning therapists, all that. It's a huge team in the radiation oncology practice. There's a lot of individuals involved, but it does go through 3-4 eyes in terms of planning, et cetera, et cetera. But they basically shape the machine or angle the machine that which can move in a 360 axis. Most common way of delivering radiation is called linear accelerator. We're literally accelerating particles and causing ionizing radiation. But you can shape the beam and angle as such to just focus on that area of interest. And we're able to see how the dose was deposited. We use machine learning too now, and AI is coming to play, all that. But with our tech, we're able to see where the dose is going and all that, and how much of the normal surrounding tissues are getting. And that's how we say we're okay, feel safe or not so safe with treatments.
Okay.
And so when we put the patient on the machine, we use that planning CT that we did pre-treatment, and we fuse it with the position the patient is in that day. And that's how we can move the patient to line up perfectly with the planning CT. So they're basically a mark on mark. And they have marks on the body as well with line up with lasers. But that's how we assure it's image guidance, because before we press treat every day, we make sure we're in the same position every time.
You don't use casting or anything like that?
We use immobilization devices.
Okay.
Absolutely. And so it depends on the site. If we're treating lung, we'll bring their arms up and have them hold a little device on top of them to bring their shoulders out of the field. If we're treating their pelvis, we'll put them in something called a vac lock. It's basically a bean bag that shapes to the shape of a patient's body. So that's their bag every treatment. And that's what they'll be positioned in. So there are different ways, externally and internally, to assure we're in the right area.
Okay. Who would be an ideal candidate for low dose radiation therapy? Kind of a one
Yes.
stage of osteoarthritis or other inflammatory conditions would
Yeah.
they
So
they can
yeah. So let me give a historical background of where this is coming from. So, the first osteoarthritis patient was actually treated in the 1890s. And it was a big part of the standard of care here in the US for many, many years. However, when opioids came into play in the US, radiation therapy got pushed away and it was not a thing anymore. Opiates were the magic do-all eventually. However, in Europe, they kept pushing on. All the first world countries there, Italy, Germany, UK, Germany being the biggest country pushing this during its time. So for the last 70 years, they have been giving low dose radiation for their osteoarthritis patients. About a third of their population ends up getting low dose radiation therapy. And so their protocol is conservative measures. You try that for a few months. But if you try that for a few months and it hasn't worked, most patients will get pushed right to low dose radiation. Steroid injections is not even a thing there because this works. This actually is more effective, works mechanism wise, and has no side effects really, or low side effects compared to steroids. So it's not even there. Even opioid is not as big of a thing as here as such. So that's where it falls. And then if it doesn't work or it comes back after a couple of years as such, and replacement's the only option left, then they'll get replaced because this is not a contraindication for replacement. You can go get replaced, in a couple months or a few years after this. It's a great insertion to hopefully avoid replacement or delay it, for a long time. But here, what's being pushed now, Astro, is our National Radiation Oncology Society in the USA. They are over this year, they're pushing benign diseases and low dose radiation therapy for such as osteoarthritis. So they're implementing their own protocol. But really, the way I've linked with the local physicians, PCPs, rheumatologists, as such, if the patient has tried conservative measures and there's a discussion of even NSAIDs at that point or steroid injections, let's have them try low dose radiation therapy because of how effective it has been shown and not many side effects. But that's kind of where I'm falling into place, or where it's moving towards, just like Europe. However, right now, I've been doing this for a little more than a year now. But in the beginning, especially within the community, the patients who I was getting were the ones where they've tried everything. They're opioid dependent. They've been told the only thing's left is replacement. They're literally, there's nothing left for them. So those initially were the patients I was seeing to see if I can help them at least. But now the protocol is getting pushed ahead. Now rheumatologists, PCPs are sending patients earlier on in the course because even per literature, it is shown the earlier radiation therapy is given in the disease process, the better the outcomes.
So is it helpful for like rheumatoid arthritis? You mentioned sorry, rheumatologist. So I'm just wondering.
Yeah, so no. So psoriatic arthritis, rheumatoid arthritis, because those are more autoimmune and the brain and the central system is more so leading the way in attack mode. This radiation wouldn't work because it's just local therapy. That's the big thing here. It's just affecting a local process, a local tumor, local inflammatory process. That's why I would say such autoimmune diseases need those systemic therapies or pills or injections, more systemic intervention to tackle the autoimmune part. But no, this, as of now, it's not indicated and hasn't shown to work on those conditions.
Okay. Are there any like conditions or patients in addition to that wouldn't be the best option for?
Really, if you've had a replacement, you are automatically not a candidate because the structure is gone to begin with. Secondly, metals in there and our particles, radiation particles will bounce right off. And yeah, really, this is not going to work. And then the other contraindication is the spine. We don't treat any spine osteoarthritis as such. Technically, we can. It is very low dose. We give much higher doses to the cord and masses there, etc., without many side effects. But the whole favorable thing, like I mentioned, was we're staying away from the central part of the body here, and we're just sticking to that for now. So that, and really, like I said, it's hard to determine per looking at X-rays you have severe arthritis, well, etc. So it is, if you've tried everything, you have symptoms, that I will give it a try. And even per my experience, I've had patients coming in for 40 plus years of dealing with it. They've tried everything out of pocket, and this did end up finally working for them. And they're if you look at their x-rays, they looked horrific. Oh boy, is this even good candidate? But they have nothing left. Let's try. And it worked. And there's some patients where it doesn't look so bad, and it won't work.
Can you think of any particular examples of a success story?
Yes, my first patient actually sent to me from a rheumatologist. She was one of his longest coming patients, but really, every appointment was crying with tears, just basically because there was nothing left for her, and she was not going to get replaced. She had osteoarthritis of a couple of digits in her right hand, and she underwent surgery there. Now she has shortened digits and deformed hand, and she was just so upset about that. So operation was not an option. So it was more of, let me just live with it and not even opioids. Don't want to deal with it. So she was sent to me. I treated both her hands, and she had deformed hands, couldn't close her fist, couldn't grip as such. I treated both her hands, and she, after 3 months, gripping, biggest smile, to the point where the rheumatologist called and said, that was just amazing, because every visit with her was just so hard because I had nothing left for her, to the point where we also published a case report on her as well together, because it was such a great success story. And then she ended up getting her niece treated as well down the road. She was dealing with that for decades as well, and walking around all happy like that. Other success stories are a gentleman just wants to play pickleball, and every year, every last few years, just not getting back to it. Treated his ankles, arthritis of his ankles, wearing orthotics. A few months later, comes in, doesn't need orthotics. His swelling actually went down, which is a mixed bag. Sometimes anatomically you can see swelling go down or changes in the joint, but sometimes you don't. But in his case, swelling did go down. He has significant swelling, didn't need the orthotic, went back to pickleball, happy as ever. And I'll tell you, even because it's so new in the US, but not new at all in terms of the medical interventions, because it's in US, it is voodoo in the beginning, radiation therapy for what, So even admittedly so, I was skeptical too, just being trained in cancer and all that, just that's our world. But when I dove into literature, and I teamed up with radiation oncologists in the UK, who has 14 centers dedicated just for radiation therapy. That's all he does. So he helped me, got me to build my program here. And he's one of the gentlemen teaming up with the big university, Rad Onc here, in the US, who are implementing the protocols in the US now in terms of making standard of care here. But yeah, that was one. And then another simple something such as guitar players. They just want to play guitar. They can't oppose their thumbs or grip and such, or they can only play for a couple of minutes. Just getting them back to playing guitar. Amazing. So even I started gaining confidence when my own data, my experience was lining up with the publications. It's like, this does work. And when I speak to other PCPs, I say, when orthopedics came into the clinic many years ago and said, hey, I'm going to put metal in there, I'm just going to replace that. I'm pretty sure people didn't run towards it, but it became standard of care, rightfully so. But it's rocky waters. But the fact that it's working, our patients have become our biggest proponents, telling other patients, their own physicians. They're just, at the end of the day, like I said, it causes mentation and can cause depression and all that, mobility. So just seeing something like that, pick them up, feel like they have control over their life, it's significant. That's kind of why I'm pushing it more now.
Yeah. Well, are you facing any challenges getting it more widely accepted here?
Absolutely, because of the radiation stigma. And, even when I have cancer patients come, they have legitimate concerns, but most of their prompted questions or concerns are related to old radiation techniques and old machines, and the news and the scares of the old times of treatment. But our machines, technology, software, etc., techniques are so improved, and they're getting better every year, where we are getting away with minimal side effects from radiation and better outcomes. But really, that has been the barrier, still is, in terms of saying, hey, radiation, let's try that. But it is becoming more popular because It is working. And, the one things when I started the program, I was wondering, does insurance even cover this? To my surprise, I would say 90% plus of insurance have always covered this. There's a whole section in most insurance companies where it says low dose radiation therapy for benign conditions, osteoarthritis percent. It's always been there, just never utilized, tapped into. And even in terms of economics, it's significantly lower than replacements or et cetera, et cetera. Decreased hospitalizations. There's so many papers out there too.
Yeah, you just answered several of my questions, right? One, does insurance cover it? Two, what is the cost effectiveness of it? It sounds like obviously it's going to prevent possibly a replacement, and it's going to really cut down on the cost of, burden to healthcare and everything. Could you explain a little bit more on what possible side effects might be?
Yes. So if I was telling patients, if you expect any side effects, it would be local, like I was saying. So we provide local therapy. So, for example, if I'm treating the knee, what do you have to worry about there? Like muscles, ligaments, all that. But in terms of side effects outside in, probably the most common, if anything, the side effect would be is skin changes. Radiation, no matter what it is, we're coming from external source and then going inside. But the skin is in the way. So hence why high dose, you'll see skin redness, darkening, hyperpigmentation. Really, how I put into layman terms for my patients in terms of what radiation therapy is I say, we're outside getting exposed to radiation every day in the sun. The sun is a big generator of radiation. We just harness that power and put them into millimeter beams. Why? For the same reason, if you're in the sun every day or for hours, you'll redden, darken, eventually get cancer if you do it for many, many years. Same thing here, but we're able to just weight the radiation beams and energies where we can say 100% here, not so much there. But radiation is going through and through. So in terms of side effects, two things I would say is we can cause inflammation before taking it away. So that's one side effect, meaning you could have a couple points increased in pain before you have decrease in pain. I do say that because of mechanism, but I haven't noticed it. And even per reports, about 1 to 2% of patients might report it. The biggest thing is skin redness. And the note on that is there's a big study done on low dose radiotherapy just to see side effects down the road a couple of years later. They looked at 1,000+ joints treated and brought them back a couple of years later, asked them about side effects, if any, and all of them but one said no side effects. The one patient of the 1,000+ said I had a little skin redness that went away, meaning possible, but really, even from my personal experience, no side effects yet. And I don't expect any. It's just so low dose. There's nothing critical there. One caveat, any radiation exposure, there's always a chance of secondary malignancy. So I would say that is probably the most concerning, the one side effect on the radar. Bigger concern in younger patients. So why I wouldn't treat less than 50-year-olds with osteoarthritis. Some institutions won't treat less than 60. It's just the younger you are, longer you'll live, higher chance of developing secondary malignancy. They've ran reports on 50, 60+ year olds, low dose radiotherapy. There non-significant correlation with secondary malignancies there. Again, because not near critical organs as such. What you would have to worry about, they did a study of shoulder osteoarthritis and breast cancer incidents down the road from caused by radiation, low, secondary malignancy, and there's no correlation. That would be probably the most sensitive, best way to see breast radiation therapy around the chest. Lymphomas can cause breast cancer down the road, but in this case, there's no correlation. So I would say side effects, if that, you might see skin redness, but that's about it. That's what I've noticed. And I haven't even noticed yet any skin changes myself over the last year.
Okay. You mentioned some other inflammatory conditions that you often use it for. Could you mention a couple?
So yes, I do treat anything so like with itis, so tendonitis, bursitis, synovitis, and then plantar fasciitis we'll treat. We treat an inflammatory process too. Dupuytren's contracture, we'll treat that as well. So those are really all the main condition. Anything with itis, so tennis elbow, golf elbow, which is pathology of the tendons and all that, itis. So we'll effectively treat that too. One cool thing, even when I present and talk to other patients at seminars, I'll bring up a slide of Usain Bolt, who had plantar fasciitis, was not even able to walk, got low dose radiotherapy, to the sole of his feet and won 2 gold medals after. It just worked so well for him. And I would say, yeah, even our fasciitis patients, it's working wonders because those are such patients too who are left with nothing. They'll be
Mhm.
shaving off the calluses on Dupuytren contracture hands or, as such, but it's symptomatic, orthotics, etc. But it's working wonders too, again, because it's tackling the inflammatory process at the root cause of it.
Yeah, I was going to ask you about the Usain Bolt thing, so I'm glad you brought it up. It's
Yes, yeah,
super
that's
cool
very
because yeah,
cool.
plantar fasciitis is definitely one of those more difficult to treat things if you kind of are doing all the things and it's still just very persistent. So this is exciting. I can't wait to, see if I can help
Yeah.
people with sending them to you. Is there anything else you'd like to share with us?
No, I mean, again, thanks for having me. The biggest mission, I guess, is getting this news out there, especially seeing the results and how it is changing lives. I mean, I don't want to sound, cliche or anything, but it actually is, which is incredible of seeing patients with no options and having them leave feeling better at least than they came in, get them back on their feet as such. That's the biggest thing. I am trying to push this treatment out there. It is there. It is covered by insurances as such, So that's the biggest proponent. I'm just agreeing, this grassroots, showing up at doors, meeting physicians, and I am seeing recurrent referrals on patients because some of these specialists are happy. Oh my! I've been telling them they have nothing left. I can actually tell them, let's have something we can try that has worked. So that's been great, and even to the point where I'm treating some family relatives, even patients are our biggest proponents. Like I said, their relatives from the north, Pennsylvania, New York, are coming down, staying with them for 2 weeks because that's how long the treatment is, 2 weeks, and staying with them and getting treated and going back home. As people are finding out about it, they are loving it for sure. And what I guess we'll say, just in terms of the treatment experience for the patient, what it would look like for them under our care. So it is done over, like I said, 6 days, 6 treatments, and the course is over 2 weeks. So we give this treatment every other day. It's Monday, Wednesday, Friday, Monday, Wednesday, Friday, usually. Most radiation centers are not open on weekends or holidays, so we don't treat it during those days. But otherwise, it is over 2 weeks. It's about 10 minutes a visit. Every treatment's the same for them. They'll be laying usually flat on our hardtop CT top table. They'll see a radiation machine moving above their actual joint and just there making clicking noises. That's how they know it's on. Some patients will come out of the room and say, did I even get radiated? I didn't feel anything. So I assure you it was on, but it is contactless, painless. Yeah, no complaints. It's usually in and out. And then I'll usually bring the patient back a month after that, their last treatment. And that follow-up is really just to make sure they didn't develop any side effects or have any issues, and to see if they had any relief by this point. I would say it's a mixed bag in terms of timing and relief. I've had patients before their even fifth or sixth treatment has been completed where they say, I have zero pain now. I've had patients the month later, nothing, but 3 months later, I'm feeling good now. And even per literature, really, I would say 3 months is the real hard evaluation point, giving time for the inflammatory process to do its thing, the body to handle it, what we just did. So 3 months is a good evaluation point of see if this worked or not. And then reports also, I will say one big question is, how long will this last? Is this a temporary relief, et cetera, et cetera? There's great reports, and I'm a little more than a year, so I'll be publishing my own eventually. But reports are pretty consistent, which is when they bring these patients back 2 years later, if they saw relief at 3 months, at least 50% were still saying, I feel great. If not, depending on the joint, of course, it was different. The numbers were different, big or small joint, but even up to somewhere 70, 90% were saying, I feel great still. 2 years later, even some 3 years later, or 50 to 70% were saying, I feel great. So it shows it's proven to have a sustained response too, it looks like.
That is super exciting. Wow.
Yes.
This is really cool. I feel like it's not
That's,
cutting edge because it's been around for so
yeah,
long,
right.
but
Yes.
it's great to see it used in other areas too. So thank you,
Yes.
yeah, for sharing this. Where can people
Absolutely.
find you? I mean, we kind of said, but where can they
Yeah.
find you if they want to work with you or follow you or something like that?
Yeah, so we're right in Clearwater. My website is clearwaterradiation.com. And there's more information on our website. We're very approachable. We're a very personable clinic. Feel free to call us, message us. You will most likely get me directly, requested or not. If you have questions, I'll talk to you directly. We are like that there. And one thing, testament is if folks can read our reviews, patient testimonials of even their own experience, just arthritis patients, and how it's worked for them. But very available, approachable, and just part of the community. Love what we're doing, and just kind of move that needle forward, for our patients, like I know you're doing. Kind of trying to stay on top of it.
Yeah, well, thank you so much, Dr. Bandar, for being
Yes.
on to the podcast today and sharing your expertise and your time with us. I really appreciate it. This was really exciting to hear about. So
Thank
looking
you for
forward to
having
working
me.
with you.
Absolutely. Likewise. Thank you for having me. Take
All
care.
right. Stay tuned, everybody, next week for another awesome episode. And thank you for listening.